David's on now.
Good afternoon, Chair. You're now live.
Thank you very much. And Jane, have you started recording as well?
Just doing it now.
Lovely.
It should be. I've clicked it, so there we go.
Lovely. Okay, so thank you very much, and good afternoon and welcome to everyone to our Governing Board meeting. I'm Dr. Elizabeth Fellows and I'm chairing the meeting today. We are meeting virtually in response to the limitation placed on governance by the COVID-19 pandemic. Members of the public have been invited to view this meeting via a link available from the CCG website. Papers for the meeting are also available there. Today's meeting is being recorded so that in the event of a failure of technology, it can continue and will then be uploaded to the CCG website as soon as possible. So we've got bookmarks on the pack of papers to identify the different agenda items. Board members, you are asked to keep your microphones on mute and to only turn these on when you're called to speak. Please only use the chat function to indicate that you wish to speak and do not use it for questions or answers, because this is a meeting in public and the public won't be able to see the chat function. So please can I ask everyone taking part to confirm their presence. We start with Helen.
Thank you, Elizabeth, I'm present.
And Karen.
Yeah, present.
Probably I should be asking you to say your full name and title, shouldn't I? So apologies. We're moving forwards. Linda.
Good afternoon, Dr. Linda Colley, Chief Clinical Officer.
Margaret.
Margaret Geary, lay member.
Alison.
Alison Jeffrey, Director, Children, Families and Education for the City Council and lead for the CCG on Children's Health Commissioning.
Carsten.
Carsten Shaft, I'm a GP, one of the clinical execs.
Graham.
Afternoon, Graham Love, one of the lay members.
Nick.
Nick Moore, GP and clinical exec on the CCG.
Jackie.
Hello, Jackie Powell, one of the lay members.
Ines.
Good afternoon, Ines Richards, Chief of Health and Care, Portsmouth for Portsmouth CCG and also Portsmouth City Council.
Dave.
Good afternoon, David Scarborough. I'm the Practice Manager representative.
Simon.
I'm Simon Simonian. I'm a GP and also clinical exec.
Thank you. Michelle.
Hi, I'm Michelle Spandley. I'm Chief Finance Officer.
Tawinder.
Hello, I'm Tawinder Uppal. I'm a secondary care consultant.
And David.
Good afternoon, I'm David Williams. I'm the Chief Executive of Portsmouth City Council.
Lovely, thank you very much. And we've got apologies from Andy Sylvester. And in attendance, we've got Jane Collis, who's taking our minutes, Justina Jeffs, keeping us in line as Head of Governance. And then we've got Anthony Harper and Kerry Pearson, who will be presenting some of the papers later on.
Chair, I'm Andy Sylvester, I'm here.
Oh, Andy, you're here.
Hello, yes.
I've
Andy
got
Sylvester,
apologies for you.
Okay. It is me.
Right, and you're here as lay member. Thank you very much. And apologies for not noticing you were here. Right, moving into the agenda, only I've just clicked on the wrong thing. So, we have got, in the wrong place. First item is our register and declarations of interest. Had no prior declarations around the agenda. Lots of shakings of the heads going on. Have we got any new declarations to be made? Okay, so we're being asked to note the register. Everyone happy with that? Plenty of shake. Acknowledgements, great, thank you very much. So moving on, we've got the minutes of previous meeting. I am not doing well with the technical aspects of these meeting notes. So, anyone got any comments or corrections on the meeting minutes from last time? Jackie?
Hello, I think I got the answer to this, but I'll just check. Under item 11 on page 8 of the minutes, we made mention of the 111 first service did not include mental health in the original pathway, and I thought there was a response as to whether that's changed or where are we then? Anyone?
I do, sorry, it's Karen. I do know that they're working on a SOP for mental health pathway, and that's in the process. I don't know how far they've got, but I certainly know that they'd identified it and they were looking at working on a process.
Would it be helpful just to, whenever that happens, for us to get a little bit of feedback on that? Or no, it's been added, if that's okay.
Yes, I can ask for the quality team, yeah.
Okay, thank you. I know you're up here. Thank you.
So any other corrections? So moving on, we've got the summary of actions as the next paper, paper 3B. All have been reported on apart from agenda item 4 about the prescribing committee impact assessment. Michelle, have you got any feedback on that?
I haven't got anything directly from Jo because, of course, clearly she's gone
on maternity leave.
I am. So I am in discussions with Simon to make sure that we consider that as part of the changes, because that was sort of like an add-on conversation that at last board, wasn't it, around just making sure people were aware of when it needed to come back to governing boards for approval, etc. So I think the actual proposal on the day got approved to, to go ahead and merge, whatever the term was, the actual prescribing committees. It was just the governance process beyond that. So yes, we will be making sure that's part of the process.
Okay, so I think we people are happy that we say that action is complete. Oh, Karen. Oh, and Nick. Sorry. Nick, did you?
Sorry, mine's not. No, it's not about that. It's about action 11. I've got.
Okay, Nick.
So yeah, mine was action 12, was about the standing orders. I think just we were looking at the majority or otherwise in relation to the practice, whether it's weighted by population or not, and I wasn't sure whether that was something that we've moved forward on at all.
I believe that's still waiting for review along with the operating model in general. Karen?
Okay, thank you.
Yeah, I just wanted to update. We were, I think Jackie asked last time about further information around the stroke direct admission target. I can just say that it's part of the Stroke National Audit Programme, and I know that the hospitals are measuring themselves against 13 key performance indicators, and one of those is the percentage of patients directly admitted to a stroke unit within 4 hours of arrival at hospital. So that's what that particular target's about.
Right. Thank you. Any other questions or comments? Lovely. So we're asked to approve those actions. And then moving very swiftly on to Linda's Chief Clinical Officer report.
Thank you. It's quite a meaty report today. So actually the first few pages are updates from various committees. I wasn't going to specifically go through them, but obviously they're there for your information. I was going to start on page 4. Item 8, just the secure mental health patient transport service contract, just to let the board know that the CCGs of Hampshire, Portsmouth and Southampton have exercised the legal extension option for a maximum of 2 years to secure this service further, and it's currently with Secure Care UK, who were originally commissioned from the 1st of April 18 to the 31st of March 2021. Some good news for the board. So CCG year-end assessments, as you'll recall, we get an annual assessment rating, and the 2019 to 20 came over as good. So really good for us, and just evidences quite a lot of work the teams have done to achieve that. And similarly, the oversight framework for patient and community engagement indicators. So this is how well we involve the public in commissioning decisions, and we got a green star. So again, well done to all the teams for that. NHS England, Chief Executive Amanda Pritchard sent out some operational priorities for winter 21-22, and the 5 main priority areas. And as you can imagine, COVID is quite high on that, both in terms of responding to the COVID demand, but also obviously the big vaccination programme that is being undertaken at the moment, but also very importantly, maximising capacity to treat non-COVID illness as well, both routine and emergency, taking into account the usual winter pressures, but also supporting health and well-being of our workforces. So that's where our focus has been anyway, and we will continue to do so. As you know, in our meetings in October and November, we've made some decisions that would involve constitution changes, and so we applied to NHS England to have these approved, and NHS England have now approved our changes to the constitution. And for members of the public, the amended constitution can now be found on the CCG's website, and we can now move forward with our new operating model. The CCG is working with NHS England improvement to undertake a governance review. We're hoping that this will be completed by the end of February 2021, and will help us shape the future. Integrated care systems. So in November, NHS England published a consultation document entitled Next Steps to Building Strong and Effective Integrated Care Systems. We have discussed it in one of our sessions, and the joint chairs of the Health and Wellbeing Board have put a response in on behalf of Health and Care Portsmouth, outlining the broad support for the principles in the consultation. There'll be more to come on that, I'm sure, as things develop. Something that I thought was important to mention is, as part of the COVID response, we are looking at redeploying CCG staff. We did this during wave 1 where was needed, and it looks like it's needed again. So pool of clinical staff, so that's the clinical executives, including myself, along with some of the nurses that have functions within the CCG, will be looking to be assigned where they're needed to help support the COVID response. For the clinical executives, we're going to coordinate that through the PPCA, so to make sure that we're given a response that matches the city's needs, and we'll be called upon when required. So this is for things like, you may have heard of things like the COVID at home service, where we're trying to manage patients at home with oximetry to prevent hospital admission, and our clinicians will potentially be helped to support those kind of services. It will also potentially involve some of our admin staff being redeployed, again similar to wave 1 where we put them in the hive. Wherever we can use our staff most effectively to help through the pandemic is what we'll do. We have checked, and our staff are covered to work in other areas, and we would hope you would support our intention to do this to help our frontline colleagues. So that was the main pieces from my report. There's now a couple of services that we need to discuss in terms of financial investment, and I believe we've got the people on to go through the papers. Is that right, Elizabeth? So we've got Kerry first, haven't we? So
yes.
Is Kerry, the Perinatal Mental Health Community Service. Kerry, do you want to pick up?
Yes, good afternoon. So Kerry Pearson here, Mental Health Commissioner for Portsmouth CCG. So thank you very much indeed for the time slot. So we just wanted to bring the paper to the sort of meetings note to say that the Perinatal Mental Health Service, which is provided by Southern Health, has got a business case going forward because they're looking for more investment into the service in order to make sure that it's fit to be able to achieve the ambitions and the requirements of the long-term plan. And basically, in short, that's to ensure that women are able to be supported, extend the support offered from 12 months to 24 months post-delivery, improving and increasing the access to psychological therapies, improving the support to dads, partners and families as well as extending the expansion of the specialist work around women with personality disorders, the trauma pathway and other evidence-based therapies. Now, the service is sort of commissioned. It's a Pan Hampshire agreement that we have, and the lead commissioner is West Hampshire. So the other CCGs, I'm aware that North East Hants and Farnham have actually approved the additional funding, but the other CCGs are, the request for additional funding is being collated, and the discussions are being taken forward to the finance leads by Jenny Irwin, who's collating all of the mental health responses for investment. But the aim is that the service currently costs us £345,000 per year, and that they're looking for an uplift of 88k in order to make sure that they can meet the requirements going forward from April. The idea is that obviously they need to increase the number of staff in order to be able to provide that sort of support. We have had a number of queries over this service over the years, which some of you may remember, because we were a bit worried about the value for money aspect of this service. I managed to meet with the consultant psychiatry lead in November in order to share and raise my concerns and my issues, because we were of the feeling that we perhaps had a band 6-7 specialist midwife and 2 nursery nurses, and we're thinking, why are we paying this level of money for that level of support? But it's become quite apparent from the conversations that I've had that the level of support that we're getting is far in excess of just a specialist midwife and nursery nurses. So having had the conversation, I, as a commissioner, am feeling far more reassured about the level of support that is now available. We still have some issues that we need to iron out. Preconceptual advice and support is something that actually, from a Portsmouth City point of view, that we're not accessing effectively from the service. So we do need to pick that up, and that's something that the service, myself and colleagues are going to be working with health visitors and midwives, etc. So there is some work to do, but I am more reassured about the value for money that this now actually provides. And I'm also aware, because this again was the query that I'd had, that we weren't aware, it wasn't clear from the conversations and the data that comes through what level of psychological input these women are receiving once they go to this specialist service. And again, it's quite clear that dependent on the level of need, the women are getting between 12 to 16 weeks of psychological support, and that can be once or twice a week with a psychologist, and obviously ongoing support with their specialist midwife at least once a week, and the nursery nurses. So there's far more input going on than we were aware of, or that was immediately obvious for some of the conversations and some of the data that we were getting through. So this is in part of a level of transformation that's been happening with perinatal mental health services. So this will support that level of increasing the level of support and access up to 24 months, and obviously increasing further the psychological therapies. There is also some work that's going to be going on around the service is going to be one of the early implementer sites for setting up the maternity perinatal mental health service. So again, we'll need to be doing some work with the service to understand what that means and how that will link with PHU, as it's now called, QA, to see what level of support will need to be happening going forward. But that's still very much in its infancy, and that work is ongoing. Hopefully that gives you a quick update of where we are, and obviously any questions, then please, I will do my best to answer.
Oh, sorry, I was on mute. Margaret, then Alison and Linda.
My question is a simple one. If we're in future reporting, presumably the data that you haven't had in the past will be included in those reports.
Yeah, so again, I think it's the problem when we've been talking to the specialist service, because they are very specialised, they understand what they're talking about when they're talking about their pathways. If you're not in that space, we were finding that we were having a parallel conversation that wasn't making sense. So now that we are on the same of that same understanding, yes, we're going to be looking at what data is coming through and how that enables us to fully understand the picture. So yes.
Alison?
Thanks very much, Chair. Just to say, investment in maternal mental health is always a very good thing as far as children's services are concerned. Just to say that it is really important, I think, that we approach this in a joined up way, and Kerry's mentioned linking in with health visiting and midwifery. I think children's commissioning in the CCG, the team that Anthony manages, are really critical in this and haven't so far been involved in discussions about this. And I'm not aware either that it's been to the maternity and child health group of the Integrated Care Partnership. That's not to say that they would oppose it at all, only that in the detailed implementation, it would be really helpful if we could get some engagement with the children's team and with the ICP MAC group to make sure that we're fully aligned in particularly in our commissioning of the health visiting and midwifery services and the family nurse partnership and the like, which of course is done in an integrated way in Portsmouth through children's. Thanks.
Thank you. Linda, then Michelle, and then finally Jackie.
No, I was just going to offer my support for the programme. I think it, is a very specialist area, and I think for the women that do need this service, it's very much needed. And I think if it's one of those good ones that do show you need to work on a pan-Hampshire basis for this kind of thing. What I'd be quite interested in the future would perhaps be a case study of what, you're saying that they're doing a lot more for the women than we're realising. Perhaps a case study to show, a success programme. That would be quite nice.
Yep, no, that works. I can sort that.
Michelle?
Thank you, Chair. Just to say for this and for some of the others that we'll talk about shortly, investment requests, that I would strongly encourage improvement in principle whilst we work through what does it mean for planning, because these are new investments that are sort of like first in the queue, if you like. They're ahead of the game, and we might need to collate all of the investment requests and have some sort of review process, because we might not have enough funding to go round. That was all I was seeking for the board to agree today.
Thank you. Jackie?
I agree with everything that's been said so far, but particularly with gathering kind of appropriate level of data and knowing that we've covered everything that needs to be covered. And part of me would include any feedback from the actual service users. And I don't know if that's already been built in or not.
Yeah, no, we're definitely working on that, because it's very crucial that service users are we're understanding what service users, how service users are being able to access the service, the level and the quality of the service that they're getting, and how well they're feeling supported. So yes, that's all part of what we'll be taking forward.
Thank you, that sounds great. And also just a tiny thing in terms of, it makes reference to partners, but of course we're in 2021 and partner being a father, but a partner, of course, can be same sex. So we haven't included. Thank you.
Carsten, then Nick.
Yeah, just a quick one. I think it's positive. As I see, it's been increased to 24 months. That's up from 12, and I think that's. I've had a lady who sort of missed the cutoff, and it was a bit bonkers. But I think that's a positive move. Yeah.
Thank you. Nick?
Sorry, I'm muting. Just to pick up on Linda's point, I agree, obviously very much support this, about the patient story and stuff. And we used to have this as part of our governing board meetings sort of moons ago, and it may be an opportunity if we're looking at some kind of real life story of the sort of things and the work that we've done, that obviously we could do that. Obviously that was when we did live face-to-face meetings, but it just might be something just to think about if we wanted to get a story or some patient level, a case study to present for either from a service user or from one of the professionals to present a bit about what they're doing to us.
Right, thank you very much. Margaret, did you want to come back in? Right. Okay, so what I'd suggest, because we've also got another item to take, I would like to look at this one first, and then we'll move on to the next presentation. So are people supportive of this investment, with the caveats that Michelle has put out of it needs to be considered in line with other expenditure and other priorities?
Yes.
People happy to support that? Thank you. And then there's definitely a push for let's have some feedback and a patient story and more data visible to the team so that we've got a really good link of this. And the final thing I've picked out is that a clear link into the maternal and child health work so that it is a really joined up service and is part of the pathways that are going on elsewhere. Does that sound like a summing up suitable for this?
Yeah.
Right. So thank you very much, Kerry. So you've got your approval subject to the numbers working out. Okay.
Wonderful.
Thank you very much.
Thank you very much. Take care. Bye-bye.
Bye-bye. So, moving on to the supplementary paper that Anthony Harper is going to present on children's integrated community nursing resources.
Good afternoon. Hi, I'm Anthony Harper. I'm the Head of Integrated Children's Commissioning at Portsmouth CCG and Portsmouth City Council. Thank you for finding the time to review this paper. Portsmouth CCG are the lead commissioner for children's community nursing across the ICP. So it's the 3 CCGs that sit around the hospital's footprint. In 2018-2019, the STP undertook a review into the structure and demands on community nursing. This renewed the focus on the 4 pillars of community nursing and drew us back into focusing on acute and short-term conditions, children with disabilities, complex needs and continuing care, children with long-term conditions and children with life-threatening or life-limiting illnesses. That led to a reorganisation of the community nursing structure that we had across the ICP, but didn't lead to any additional resourcing. In September, we agreed with the ICP to review the resourcing element of the community nursing structure to understand the extent to which it is able to meet this clinical demand and challenge. The review has sought to understand the impact of increasing numbers of children with disabilities and complex needs, to understand the need for an equitable access to specialist school nursing, so across our mainstream and specialist provision, looking at the opportunities to improve the positive impact we have on the urgent community care pathways, and also to review the best practice guidelines, both of the long-term plan and of NHS England's sustainable community nursing review. What the resource allocation would allow us to do is to increase the hours that the service is available, so delivering a nationally recommended 8 till 8 service across 7 days. It will increase flexibility across the service, so we have seen some integration of the constituent parts of community nursing, but we are driving forward more of that so that we have a team where we're able to dial up and dial down support at the right parts of the team at the right parts of the year. So, for example, our urgent and emergency system during the winter sees more pressure than it does during the summer. Our specialist school nursing team, as part of our transfers and planning, will see more pressure in the summer term. So we're looking for the system to be able to kind of flex across those priorities. This will allow us to bring together our specialist functions, our asthma nurse, our epilepsy nurse, our continence nursing, from the various places they are at the moment, and bring together not only some clinical leadership around those specialist areas, but it will also allow us to disperse more of that knowledge across the community nursing team and gain more benefit from that being in a single place. It looks to establish a new advanced nurse practitioner role within the community structure, and also underpins the clinical leadership of community nursing in a way that will only allow us to kind of grow and develop that system. It's worth noting the advanced nurse practitioner role will bring a host of new and exciting opportunities with it. This will provide an interface between primary and secondary care, increasing our diagnostic and prescriptive abilities within that system. It's been shown in areas where it's been piloted. There's a case study of Salford in the report, to reduce acute hospital admissions and to improve community management of children within those 4 pillars I mentioned earlier. The posts would be established across the ICP, one with a focus in Portsmouth, one with a focus across Fareham, Gosport and South East Hampshire. The requested investment across the ICP is a little under 522,000. For Portsmouth specifically, that's an investment of 198,000, the details of which are noted in the paper. The investment from Portsmouth is largely predicated on needing the investment from the other two CCGs, the decision of which I believe is being taken next week through their kind of board structures. In terms of our evaluation and next steps, we're very clear about the intended impact of improving these services and extending what we're able to do. And at point 8 on the report, we've listed our next steps in terms of our improving our data sets. We're keen to have a better understanding about the added value to the system of increasing this work, of the benefits in improving the reduction in acute admissions and better understanding the management of children's complex needs and seeking to reduce the impact on specialist services and improve access to community provision. I think that probably sums up where we're at.
Lovely, thank you very much. I'm going to ask the first question here. In the past, this service generally has struggled because of a lack of workforce and difficulty to recruit into the posts. So even if we've got the money, is the workforce out there to fill these additional roles?
There are absolutely some challenges with that. What we have discussed with the service is how we can look to improve staff retention. Part of that is succession planning, the development of the ANP role, which will look to initially appoint as a band 7 specialist nurse with a 1-year training programme to bring up to ANP qualification, will provide an additional role within the community that isn't currently there, which will look to retain senior staff with experience without them needing to move into other environments. It also looks to extend the band 5 offer that we have for staff across and putting more of a mix in. We've also spoken to them about introducing a band 5 associate nurse post, which is essentially an apprenticeship role, which would kind of sit across Solent's community service. So there should always be somewhere for that apprentice to kind of be deployed once they finish their programme. So absolutely there's a challenge, but we hope that we have looked at ways to kind of rise to that.
Lovely, thank you. Carsten.
Yes, I fully support this. Obviously, as long as the financial abilities there to finance this, then that's, you know, it sounds like a great supportive plan, and it looks like it's been well thought out in terms of sustainability. Just a comment. We're not going to use the acronym CCN anymore. Is that right? It's now CICN? Is that because we were still using both in the paper?
Yeah, I think what we're trying to do is move to a position where we as a system are looking at an integrated children's team. At the moment, there are still discussions around specialist school nursing, around CCN, around COAST.
Right.
What we'd like to do is to draw that together. So I think CICN is perhaps where we've settled, but we're not totally sold on that.
Okay, cool. And the other one is just a bit of a modification, if possible. I mean, no, you're most probably right in this. It's where it says GPs often misdiagnose I can't find it. I've been looking for it feverishly. Where they often misdiagnose. It sounds a bit GPs tend to do a relatively good job, and it sounds a bit harsh. I would have thought, if you know what I mean. You can phrase that more elegantly, if you know what I mean. Yeah.
Absolutely noted.
There's one paragraph where there's a few of these sort of unpleasantries.
Yeah, I think it's under the specialist asthma nursing
something like
section,
that,
which is on page 9.
Yeah, because we do need the support of the specialist, and you know, if that's at hand, then we'll do an even better job. Yeah.
Thank you. Michelle, then Jackie.
Thanks, Anthony. Really helpful to understand the background, etc. My main concern would be, you're asking for £500,000, and then you talk about some savings elsewhere. But it's not clear to me how you're reinvesting those savings. So I think you might need a little bit more work with the teams on, if we do this, it means we wouldn't have to spend X, and therefore there might be an avenue to find some funding stream without necessarily adding to our utilising all of our growth, etc. Just a pointer really, just so that you can refine the business case just a little bit more.
Absolutely. The discussion we'd had with Nikki and with Andrea was around the longer term savings. So in years 2 and 3, not investing further funding in the acute admissions system and not investing any further in Solent's community nursing as they find those efficiencies and so on. It was really difficult to begin to articulate what that looks like because they're kind of savings predicated on managing this. But I absolutely take your point. We need to be clearer about that.
And to that end, Anthony, it would be helpful if Solent and PHU recognise that as well, so that we can start building that into our programme. So we're going to invest in this, which means in year 2 we don't invest in Solent for X or Y, so that it's really clear for everybody.
Yeah, and they are absolutely aware of that. The plan is for us to rebuild the service specification and the contracting arrangements. So rather than kind of tweaking around the edges, we're going to go right back to the beginning and start again. And those plans around further savings and investments will form part of that structure.
Good. Sounds like a good plan.
Jackie?
Thank you. And a couple of points of clarification, if you don't mind, and then another couple of very quick queries. If I understand correctly, with what you're proposing, there will also be 24-hour access for those young people at end of life?
Yes, there currently is 24-hour access. The challenge the team have is that impacts on their core hours. So when a nurse is called out in the middle of the night, that impacts on duty rotas. What this will do is give a more robust element to that 24-hour provision for life-limiting, life-threatening illness.
Okay, I just wondered if that should be put explicitly at the front as just a continuation of that. And the other thing was, if I've understood correctly, not accounting for travel was severely underestimating the amount of time that would be needed to deliver some of these services. And are you more confident that now we factor in the time of travel, that we have a more realistic picture of who's needed where and when and why and what, and that we're paying adequately for the service?
As confident as I can be. We've done a lot of work in terms of staff scheduling with Solent, and I've got some very detailed worksheets and so on that kind of sit behind this. So yeah, I'm as confident as we can be that we are funding this in the way that we need to long term.
And then very quickly, if you'd be patient with the similar comments that I had before, was what about engagement of service users and the young people? How are we getting that on board? And how is this all sort of joined up with, say, the other children's services, which is what Alison asked before? How is this all interlinking? So that be it a physical or mental health issue that might arise with your condition, that you have a joined up holistic approach. And is one AMP going to be enough? Then I'm done.
Okay, so across the ICP, we're looking at 2 AMP roles. What I think we need to do is to establish those and understand the breadth and the working with them. I think there are probably opportunities for AMP roles to exist in other areas of our community provision, but at the moment this is just looking at the community nursing element. So I think absolutely 2 at this point within this structure. In terms of child voice and patient engagement, the children's team at the moment are working on a kind of a whole service engagement strategy, building on the co-production work which the City Council do so incredibly well. So we're looking to draw from the lessons in that and build a whole service strategy, which will be effective from the 1st of April. That will look not only at what the CCG does in terms of engagement, but also the expectations we have on services we commission and how that's fed back into our performance review structure. There's a new element to the performance review meetings that we'll have with Solent that asks them for case studies and feedback and information around that patient experience. And the other question was around linked up integrated working. So absolutely, this has been done with the lens of children's services across and looking at how we can better engage the whole system. For example, the nursing support for children with complex needs. One of the benefits of the increase in resource is so that we can do more work with families, so they're much more resilient, much more confident to access community resource rather than needing to rely heavily on specialist resources. That feeds into a review the local authority are doing around short break systems, which we've joined them in doing. So there'll be a whole system short breaks review, which relies in part on the community nursing structure changing and having that resilience function.
Thank you. It's very helpful. Thank you.
So we've got Alison, Simon, Linda, then Margaret. Alison.
Thanks very much. Firstly, really just to pay tribute to the work that Anthony's been doing leading the children's team since he's been in post, because I think most people who are aware of that work will see a really big difference in the purposeful clarity and a lot of progress that we've made, fantastic progress around, for example, health assessment for looked after children, and the detailed understanding that Anthony has developed really quickly of a lot of these NHS services, I just think is really impressive. And the way in which he's been able to integrate that with the work of colleagues in the City Council, obviously very supported by the structure, but he's just doing a fantastic job on that score. Secondly, the point I originally put my hand up to say is, while we absolutely accept the importance of the invest to save equation, there's also a demographic element here. We just have increased numbers of children with complex needs, complex disability. And the City Council is looking at significant spend in special school capital building and the investment through the education recurrent grant in meeting the needs of these children. And in fact, this is a really good joined up piece of work, because one of the key elements here is asking for flexibility so that we have nursing not just in special schools, but actually where it's needed for children who have an education, health and care plan and complex disability, but are being educated in a mainstream school. So this is generally across the piece for all agencies. We have to respond to this additional number of children with these complex conditions. And so we may be able to extract savings, which would be acute savings, as Anthony's alluded to, and that would be great. But we also have to meet need here. And so I would make a strong pitch for the CCG to recognise the needs of this increased cohort of children.
Thank you. Simon?
Hi, Andy. Thank you very much for that presentation. I just wanted to ask about Section 7 for the additional investment required. There's the Band 3 and Band 6. Is that costed only for the unsociable hours? Or is that, so that's kind of extending an existing role to incorporate unsociable hours, is it?
Yeah, absolutely. So we're looking to extend the service so that it operates 8 till 8, and there are some residual costs. So we're not fundamentally adding to the number of Band 3 posts, but in order to stretch those posts over their hours, there are additional costs.
Okay, it's just really, I think I was going back on the comment of people before with regards to saying that with staff robustness, just because obviously the service has faltered at times because of getting people in post. Are there people already then in post who want to do the extended hours?
There is an element of that, absolutely, and there will be an element of recruitment. So I think across the whole of the system, there are 8 new whole-time posts, which isn't a significant number.
Okay. Thank you.
Linda?
Yes, thank you. So will all of the nurses be trained to do all of the roles? So would the coast nurses be upskilled to do the complex needs children, or will they still be sub-teams within the teams?
The plan is over time that we will develop an integrated ability for the nurses to move between those constituent parts. As part of the new service specification, we'll build an implementation plan and look at what that core qualifications and skills matrix looks like and how we best manage that. But yes, that won't happen immediately, but is absolutely an ambition.
And the only other thing is the coast nurses used to rotate into the PDD for upskill and clinical supervision. Is that still the intent, that they would get some supervision from the paediatricians at the hospital?
Absolutely, and is one of the key roles of the 2 AMP posts that we'll put in as well, and the interface between the acute system.
Good, thank you.
Right, Jackie, did you want to come back in?
It was an old hand, but while I'm here, I'll take the chance. The out of hours, will you still get the same skill and expertise as you would do in hours, just because it says a band 6 only for later on in the evening?
Absolutely. So the specialist ANP, the hours, kind of core hours across a week, they will be available at the weekends, but there's a limit across the totality of that to try and keep the costing down. But the skill base will be there. We're not looking at offering different levels of provision over the course of it, and the training and implementation plan will be key to making sure we succeed with doing that.
Thank you.
Margaret.
Yeah, my hand's been up and down because I think it's been largely answered, the question, but in relation to complexity that you talk about and the training, mental health is a focus there. Is it a very explicit focus there? Because it doesn't come through in the report as such.
There will absolutely be an element of that. The SCMH strategy that Stuart McDowell in my team is leading focuses much more on the skill set required across the system to help and support children and young people with mental health issues. There's a piece of work going on at the moment looking at the pathway that young people will follow and the requisite skills and requirements for the whole of the system. So there will absolutely be an element of that. It's not specifically written into this structure as it sits with another piece of work.
Are you happy with that, Margaret? You sound a bit doubtful.
I'm just wondering if the mental health is an issue that doesn't just sit in a box remotely and is linked to other complexities, isn't it? So I just wondered how the nurse training covered that.
Okay, thank you. Michelle, then Alison.
Does Alison want to come in? I suspect Alison's going to say the same as me.
Well, I don't know, but I was just going to reassure Margaret about our mental health strategy, because the strategy is really broad-ranging and looks at all the different children's workforce groups. It's not at all about CAM, specialist services. It's actually very, very broad, and you can see that actually if you have a look at the inspection report written on us in December 19, Joint Targeted Area Inspection of Mental Health. You can see this really, really broad reach. So these nurses will be part of that wider system in which everybody's thinking mental health. Mental health is everybody's business. But we will absolutely hear your message about making sure they have that understanding and the skill levels that they need to really play their part in that.
Lovely. Thank you very much. So we are being asked to consider the additional investments to support the future development and sustainability of the Children's Integrated Community Nursing Service. Now, within that, we've got Michelle's challenge of, so what are the savings? Can we attribute that to any of the expenditure? And if I'm right in thinking, Michelle, you're actually pushing back and saying you need more detail. You feel you need more in this business case for us to approve, or am I wrong?
I'm going to refer back to what I said earlier in terms of if we are content this is the right direction of travel, I'd be content with us saying approval in principle to continue the work. But the issue will be around, do we as a whole system have enough funding to do absolutely everything that we want to do? Because, you know, it's £500,000 here, £500,000 there. It will soon tot up, won't it, across the system, and then we'll go, oh, but we don't have enough money to do the next thing that comes on our agenda. So that's why I was saying I think we probably need to gather every like we would do in a normal planning process. We're sort of out of sync, aren't we, in terms of planning because of the COVID-19 pandemic reaction that we're currently in. So we're seeing business cases come to our governing board more piecemeal than we would have done in the past. But there's a whole host of other pieces of work that are ongoing. Alison's mentioned the children's and maternity agenda specifically, and the mental health bit. So there are other things that need to come to the governing board and say, in order for us to address everything that was in the long-term plan, we need to invest these things. We may or may not have enough funding to do all of those things. So as a CCG, we would then need to say, okay, so we've got all of these investment requests. Do we have enough money? If not, how are we going to prioritise going forward?
Lovely. So you're not pushing back to say needs more of a business case at this point?
I think
work should carry on.
I think Anthony's already said he's got some extra bits to do, and I was just making sure that we were heading in the right direction, which sounds like, you know, the teams are working much more closely together, and we need to make sure that we have more of that, don't we, so that we all understand the interdependencies on anything that we approve in the future.
No,
so
that's lovely. Thank you.
I'm saying I think you know need to continue to refine, which is what I heard Anthony saying he was going to do anyway.
Lovely. Alison, did you want to come back in?
Well, I was just going to ask really what the process will be for the prioritisation of different investment proposals, and how that will work, I suppose, and then advocate for one of the criteria being demographic need in terms of changed landscape there.
And I think it would be helpful for each of you where you're leading in the ICP world to make sure that those conversations are being had. You'll also know, and Linda will know, that in the ICP strategy group, they are trying to gather all of those important pieces of work, aren't they, around non-elective, elective, children's, maternity, mental health, trying to make sure that we have an agreed and a joined up programme of work. But what we haven't done is bring them all together in one place. And that isn't for the want of trying, that's because every time we try and do that, we haven't, you know, we're now into the second wave of the COVID-19 response, aren't we? And therefore some things get deferred. And that's when we get a little bit of confusion about what is the process, where did we get to, what is the process from now, what are the rules of engagement, because quite a lot of the good work that's being done to date may be stalled because people are not necessarily concentrating on planning for the future at the moment. They're trying to deal with here and now, aren't they? And so we are trying to make sure that we keep things moving along. It's a difficult situation just at this moment in time. So hopefully we'll be a little bit clearer around planning processes. And I think last time we spoke, we were expecting some planning guidance, probably about now. We did have a planning letter on the 24th of December, but we have seen no further guidance since then. So there's a little bit of a hiatus, I suppose is what I'm saying. I don't want people to stop what they're doing because, you know, we've got some really good pieces of work underway. And I think we're nearly there on trying to gather all those strands. But I'm just a little bit worried that we haven't quite got the financial framework to sit around that currently.
Thank you. David.
Thank you. I think, Michelle, I think if this is going to be dependent on the timeline from the centre and also some sort of filtering by the sound of it at Portsmouth South East Hants level, I think it would be really helpful. Could you just circulate what our expectations of the timeline are? Because otherwise we are in danger of delaying very necessary work because of a hiatus elsewhere, and at least we could be getting on with our own internal prioritisation and refinement, couldn't we? But you know, it would be a shame if the work's just getting held up. I think it would also help Linda and myself and others in terms of the pressing for progress and lobbying for action at other fora. And with that, I'm afraid I'm going to have to leave for another fora. I do apologise.
Well, thank you very much, David. Are you in support of this paper itself?
I am, but I can well understand where Michelle's coming from in terms of principle and detail and so forth. You know, yes, it's really important work.
Okay, thank you, David. So, I think the what I'm asking you as a board then is twofold, really. One is, are we in support of the direction of travel for a Children's Integrated Community Nursing Team? People in support of that?
Yes.
That we recognise this will need additional investment, and with the caveats from Michelle of, and we haven't got a clear prioritisation process currently. So we ask that we get to hear how that's going to happen, what the timeline is, so that we can understand where this goes next. People are happy with that?
Yeah, agree. Yeah.
And then, Anthony, thank you very much for your presentation, for all the hard work so far, and continue to refine it as per Michelle's requests.
Thank you very much.
Is everyone happy with that? Lovely. Yes. And I have to add to Alison's thanks, Anthony, working with you across a variety of things in the children's world is a breath of fresh air. So thank you very much for all your hard work in this arena. It's been really good. Thank you. So, thank you very much. That is the longest Chief Clinical Officer report I think we've ever had.
Hopefully won't be repeated next time.
Well, yeah. And I think it is a reflection of the times we live in that those papers did come in late, and we do apologise for that. It's not our normal style to slip things in, but thank you for bearing with us. So over to Michelle for finance and stuff. Oh, Alison, did you want to say something? No, go on. Right, Michelle.
Thank you, Chair. So the finance report you received in the papers was for November, so month 8. We're in the process of closing down month 9. The board report shows that we continue to achieve expected planning values. At the time of writing this particular report, we were still awaiting some of the retrospective allocation funding for the hospital discharge programme. That will always be the case. We always end up in a retrospective process from that point of view. So we're still awaiting that allocation, as we are still awaiting the month 9 allocation as well. In terms of the financial forecasting, we are still working as part of the Hampshire and Isle of Wight system to ensure that we understand and are a little bit more transparent about our finances, because as you know, we are then treated as Hampshire and Isle of Wight SDP as a whole in terms of our financial position too. And you'll also appreciate that given the changing circumstances we find ourselves in, some of the risks and opportunities are fairly volatile currently. So when we sat here couple of months ago, we were trying to pick up elective activity, weren't we? But now we find ourselves in that second wave, and that now is not all of the activity is happening in the same way. So, you know, we might have an opportunity of less expenditure in one sense, but clearly we'll have more expenditure dealing with COVID-19 patients. So we're all trying to work in a very volatile situation. But as we sit here today, I am expecting the CCG to achieve its current targets, obviously, you know, the surplus position. But as I say, we are trying to work really closely with our colleagues to make sure that we utilise our funding as appropriate for the, you know, provision of service. That's all I wanted to say just at this moment. I just wondered if there were any questions anybody had, any specifics on our financial position. Jackie.
Thank you. I thought I saw Graham's hand go up before mine, but I'll leave you just for a minute. You just really made me think, Michelle, with your other comments on the other two items before, when we're looking about how we balance our budgets and how we spend and get best value for money. For example, those two additional costs, have they been factored into our current planning and financing? Or will they come out of, I don't know, say, reserves and contingencies? Have we got enough process to kind of, in difficult times, keep an eye on how we plan our budget and therefore plan our work to meet our priorities?
Yes, Jack, in terms of the two investment requests that we received, that investment request is from 21-22, so it doesn't affect this year's finances per se, but clearly that's what we're trying to look towards. It is the future, and remembering that we had a long-term plan, didn't we, that the CCG was aiming to achieve. So that's what those business cases are trying to do, is more around looking at future state. And that's why I'm just a little bit hesitant to give the green light to absolutely everything until we understand what else is on that shopping list, for want of a better phrase, and just to make sure that our future finances remain as well controlled as we have in the past. But, you know, I am, you know, not naive to think that we're not going to invest in anything. It's just making sure that we place our money in the places that we definitely need to, given the current situation. Does that help?
Yeah, it did. It's just made me really mindful that if we want to keep, especially, for example, doing what we can for health and care Portsmouth, that we do have we try and maintain some sort of robustness on the finances and what we do or don't commission, so that we can get what we need for the city. And also at different levels as well. So it just made me think. And then in terms of the reserves and contingencies on the paper we've got, are we spending more of that than we had anticipated? Because we're waiting for money to come in.
Because of the current financial regime we're in, the hospital discharge programme funding is coming in retrospectively, which is why it looks like we're overspent on our main contract lines, and we have a line that says, and we're anticipating some additional allocation to cover that off. I don't believe that's at risk. I just wanted to make sure that it was clear that we were currently doing that in a effective way. I don't believe that we've got any outstanding questions or worries from that respect, but it's something that we just need to make sure that we are transparent with.
Thank you. That's really helpful.
Graham. Graham, are you on mute?
I very cleverly took my hand back down, but not the mute button. Let's try again, shall we? couple questions, Michelle. I think one actually kind of touches on to what Jackie was asking, but obviously I quite understand the point you're making that at the moment we've got a surplus, but there's a likelihood that that will be redistributed into the wider system, and I haven't got an issue with that. I understand that. But equally, I understand our needs in health and care Portsmouth, and I just wanted to check what's the mechanism by which that is actually decided. Are we, you know, part of a group that has that discussion, or is that more of an imposition? Or
no, it's not an imposition. To make sure that you're clear about that, but part of some of the allocations that we have received. For example, we've received some extra what's called COVID-19 allocation that we as a CCG don't currently require, which is why we're able to say we can achieve a surplus compared to others. So it might be, for example, that because we don't necessarily require that COVID-19 allocation, but others might do. You know, in the next few months, so that's the sort of thing that might get a redistribution. So that's the type of thing that we are dealing with in a very volatile way, as you can imagine, because what we thought might have happened 2 months ago is very different now. So we just, you know, that's why I keep saying, you know, we're trying to be open and transparent, understand the risks as well as some opportunities that might be exposed, so that we all achieve what we need to from a financial perspective going forward, and that we don't inadvertently make some people's lives hard when we don't need to, if that makes sense to people, because at the end of the day it is public purse, isn't it? We need to make sure that we're spending it in the right way. There is quite a lot of scrutiny on what people are claiming for, etc. So that I've already mentioned the hospital discharge programme, haven't I? So there is a lot of scrutiny on what is being charged through that, just to make sure that we are recording our activity and costs appropriately.
And the second one was a more specific one on the penultimate sentence on the summary, and I realise this was written some time ago. It says includes provision for any negative impact on the cost of a no-deal Brexit. Given what's happened, is it too early to say that provision's probably unlikely to be needed, or is it still needing to be looked at?
I think time will tell, and I suspect that sentence is probably linked to prescribing and drug provision, etc. So as we go through the next couple of months, that'll be clearer, won't it, in terms of making sure that we are getting supply. My understanding is that is currently okay, and therefore yes. So we would have made sure. So we saw this time, probably about this time last year, our drug costs went up because there was that risk that we might not have received supply because of Brexit, and that's what that relates to. But it's less of it's receding, I suppose, as a risk.
Thank you.
Sorry, thank you very much. Thank you, Michelle. Do you want to talk us through the performance report, and then we will go back to Helen? And I have to apologise, I missed Helen out, so we'll go back to Helen when Michelle's finished.
That's fine. Again, I probably wasn't going to say much more than the introduction that's included on the paper, that we continue to receive the normal performance data as much as people are able to provide. And therefore we do continue to report against national standards. Many of those standards are being achieved despite our current response to the pandemic. However, we do from time to time see deteriorating positions and fluctuating positions depending on where we are. So the report highlights 111 call answering performance, the referral to treatment programs and diagnostic waiting times. And that it also provides a little bit more information in terms of the annual performance assessment that Linda reported in the clinical officer report. I was then just going to ask for questions, if that's okay with everybody.
Any questions? Jackie?
Jackie?
Hiya, can you hear me okay?
Yeah, yes, I can.
There was mention about IAT entering into treatment as halved, and it made me think, is Positive Mind still able to operate during times of COVID? Have we been able to maintain some level of service there, which might have helped?
Yes, they have.
Yes,
they've been operating by telephone in lockdown, and doors have been open otherwise.
Well, that's great stuff, I think. And with the 111 calls, calls have reduced by 21%. Is that calls to the service have reduced by 21%, or I don't understand?
I would have to go back and look at the specific details on that. You have to remember that also going through the 111 service is the new 111 first as well, isn't there? So there have been issues around additional activity, which was expected, but also SCAS who provide the service to us have had difficulties in staffing due to sickness, etc. as well. So they have ongoing issues. They had issues before, didn't they, on staffing, but exacerbated a bit more by COVID response as well. But Jackie, I'll go back and just make sure that that's clear in future when we're talking percentages and fluctuations, etc., that we make it clearer.
I know that calls were high in October with 111 due to the schools returning, and a lot of questions around schooling in September and October put figures up. Schools and families settled down into November. That allows for some of it, probably not all of it, but it will be some of it.
I'll double check for you, Jackie, and make sure that we get back to that.
Okay, any other questions? Are we happy to accept this report? Lovely, thank you. Now back to Helen, and once again, apologies. But the floor is yours, Helen.
Thank you, Elizabeth, and not a problem at all. So I'll share some slides. Hopefully you can see that, and the slides will be available to share with members and on the website after the meeting. So I'll just cover the new infections or cases in Portsmouth, the weekly rates, age specific as well, pressure on the local health system, and then I'll cover deaths as well. So I won't cover this, it's just the normal caveat that some of the data is visual sensitive, but none of the data in these slides is. It's all data that's available from websites that people can access, and the references are on each of the slides. So if we take the current infections in Portsmouth, you'll see on the left-hand side, this is the 7-day rolling average of COVID-19 cases. And you'll see really optimistically there, we have got a reduction in the 7-day average of cases. So it's begun to reduce, which is really promising. But obviously, it's still quite early days, so we will have to watch this. But we are also seeing numbers of outbreaks and cases in enclosed settings. So we are still seeing community spread across Portsmouth, even though this is starting to promise, but which usually takes about 2 weeks of seeing a slowdown in the rate of infection to impact on perhaps NHS pressures in the acute hospital and in primary care, but also on outbreaks and particularly in older settings. So this is just what we call our spark loans. Okay, on the left hand, on the right hand side, sorry, you will see that we have 1,349 new cases in Portsmouth in the last 7 days, which brings our overall infection numbers to just under 11,000. And I won't go through, you'll also see the comparative there with Southampton, Hampshire, and the Isle of Wight. This is a really, I think, more helpful slide in that it really describes the situation and the comparators there on the right hand side. So you'll see there, again, promising across the Hampshire, Portsmouth, Southampton, and Isle of Wight patch, all unfortunately apart from Portsmouth are seeing a reduced percentage change in the last 7 days. So this is our rate 100,000 in the last 7 days. Having said that, Portsmouth is still only got a 2% increase, and that has been coming down over the last few days. We're hoping it will go into a minus number in the next couple of days. But what we're seeing across the whole region now is a slowing down or plateauing of the infection rate. Fortunately, Portsmouth is still just ahead of the England rate 100,000 average there and South East, but it's still well below some other areas, particularly in this region. Slough still has the highest rate, 100,000 at 1,044.5, and again there's some other areas in the patch that you can compare to. The one thing I would say is that some areas have been much higher than Hampshire and Isle of Wight, like Kent and Medway, are now coming down as well. So it's starting to see regionally, and on the left hand side you can see the map which has the rates of 100,000 in colour coding there. You'll see that Isle of Wight, even though it is coming down, is still seen as having a high infection rate, but it has come down from being over 1,000 in the last couple of weeks. So an improving picture, but it's still early days. Again, then if we look at the different age bands, this chart shows us the rate 100,000 cases in the last 7 days, but split into the different age bands. And again, the rates are now falling in all age groups, which is very promising. Although, as I said, it's still a little bit early to get too confident in that at this stage in the pandemic. And again, we have then produced the same data, but for the under 21 split into the age bands, approximating the education stages, so you can kind of see there. So what we're seeing now is a rate falling also in the primary, secondary, college, university age pupils. The only one that is rising slightly is in the very young age group, which is our preschool. But it's important to note that has always been a very low infection rate anyway. I think all of this evidence shows us that the current lockdown, although is being very, very difficult for people, it is starting to show an impact in terms of reducing infection rates, and therefore, which will come into the next slide, the pressure onto the NHS. So everything that we are asking our residents, patients to do in terms of the lockdown and the restrictions are having an impact, albeit it's so far impacted on our community infection rate coming down. What we tend to see is, I think I said at the beginning, is it takes about 2 weeks of that community rate of infection to come down to see a direct impact on the NHS. But we are starting to see some promising signs. So nationally, at the stage in January, we are still seeing increases in hospitalisations, intensive care unit admissions, and mortality, and they are still increasing. The highest rates of hospital admissions are still in London, and we're seeing in terms of the regions impact of increasing rates still in London, the Midlands, the North West, and Eastern England region. But this just gives you an overall on that top right-hand side table of the increase across the regions. And if I take that, we are still seeing an increase in the hospital activity in Hampshire and Isle of Wight. But specifically, if we go into the Portsmouth Hospital University Trust Commissioners, we are still seeing an increase, but some small movement in terms of that increase slowing. So again, this gives you the bed occupancy, which is currently at 92.8% as of the 18th of January. We've got still high sickness, workforce sickness absence, 10.8%, due to mainly due to COVID, and we have seen an increase in the our ITU beds, intensive treatment unit beds, ICU beds, with 51 confirmed COVID patients and admissions there at 381. Although in the last 7 days that is down by 2%, which is again promising. Again, this just breaks down, you can see there on the top, it breaks down the bed occupancy as of the 14th of January into the different COVID in terms of the ITU, so whether it's mechanical ventilation, non-invasive ventilation, oxygen there. But again, what you'll see here on the bottom graph, of course, is that even though we're starting to see a slight reduction or slowing down of numbers of bed occupied by patients with coronavirus COVID-19, it is still very much higher than where, and therefore the pressures are greater than we saw in the first wave last year in March, April, May, June. So again, we're seeing much higher pressures in the NHS than we saw last year. And then if we just finally go on to deaths, you'll see here that we've had 131 COVID-related deaths within 28 days of positive tests recorded in Portsmouth since the end of October. And then if I just look, this is perhaps a more helpful presentation, is that we show what we would say in terms of what we'd see as normal or average to excess deaths. So you'll see in the bottom table, you'll see there the number of deaths against the, so that's the grey and the slightly redder lines, and then you'll see the average weekly deaths over the last 5 years are the green triangles. So what you'll see is that we have seen a greater than expected or excess deaths in the last couple of weeks, although it's looking better as we move on to week 53, which is a bit of a bizarre because we don't have a 53rd week in the year, but for every 5 years, just because of the way the data is presented, we get an additional year. But again, this is starting to look a little bit like the deaths are slowing down in terms of that rise, which is all optimistic data. But we're certainly not out of the pressures yet. Would be my final comment. And that's it on the slides. I'll stop sharing.
Gone mute. Have people got questions for Helen? Yeah, thank you very much. And it is very encouraging seeing the figures just tipping down now again, thankfully. Jackie.
So I was just going to take the opportunity to ask, what is it locally within Portsmouth that's driving was driving the increases in numbers?
So that's a really difficult question. So obviously there are several factors. We do have community spread across Portsmouth. We are obviously in hopefully tailing out now, beginning to tail down on the second wave, but it is normal, obviously, in a pandemic epicurve to see obviously the numbers going up. We are not exceptionally different from other areas, but we do have factors, I think, in Portsmouth. We are a high density city area with areas of deprivation, which certainly impact on COVID numbers. However, we are also seeing, as are other areas, very much the new variant in this second wave. So we've started to see the new variant, which is talked about. I won't call it the Kent variant because I don't think we should call it by a name. It is a variant of the current coronavirus that has been it's not more serious in terms of the impact of illness, but it is certainly more infectious and transmissible. And we have seen that growing across the whole of the southeast, starting in Kent, but spreading then westward. And northwards as well. I think we're just now, so we can see that the figures in Kent are coming down, and the figures now across most of the southeast are starting to come down. We just seem to be coming down slightly slower than some of our perhaps neighbours in Hampshire, Southampton, but certainly not in the Isle of Wight, even though their numbers are coming down. You'll have been aware that the Isle of Wight have maintained a very low infection rate since the beginning of the pandemic last year. But once this new variant started to spread in Isle of Wight, their numbers have gone up significantly, much higher than ours actually, to well over 100,000 population. So they're coming down now, which is great, but as are we, but just slightly slower. And I can't right now, we're looking into why that is, but we're not quite sure. But the main thing is that we are starting to see a slowing down of that infection rate rise.
That's helpful. I just wondered if locally, if there was other things that we needed to do that would be specific to our local population that would be helpful in reducing transmission. That's why the question.
It's the same. I'm sorry, it's not too good an opportunity for me not to say that the main things that we all need to continue to do are the same as we've said since the beginning, which is really that hands, face. We really need to encourage and continue to encourage our residents to obviously wear face coverings when they're in public places. Well, the first thing is to stay at home, actually, I should have said, to stay at home if you can. And when you are out, to wear face coverings, keep your space and wash your hands regularly. They still are the most effective way of reducing infection rates. And we know that people are tired now, and hopefully with the vaccination programme very much in place now and starting to roll out, we're hoping that will have, an impact as we come out of the second wave, or slow down in the second wave.
Thank you.
Thank you. Any other questions for Ellen? No, thank you very much for that comprehensive update, and we keep our fingers crossed that all of us in the city follow your guidance and stay at home, wear our masks and wash our hands. So thank you very much. We will move on to the agenda again, jumping around. We've got the Governing Board Assurance Framework and Corporate Risk Register, I believe, is next, unless I've made another mistake. I hope not. So this register has been reviewed considerably. There are quite a few updates and several risks have been rewritten. They are listed on the front of the paper. Are there particular risks that people want to go through, questions you want to ask about them? I know it's been looked at Audit Committee as well, and we'll go back to Audit Committee. Graham, have you got anything you want to mention? Or are you looking as if you're about to say something?
I don't need to put my hand up, Elizabeth.
Well, it helps with people with cameras on. You can see when you're starting to think.
Probably a couple of things I just mentioned in light of what you just said latterly, and I can probably pick up with Andy as chairs the Audit Committee outside. I think I'd probably appreciate we have it as an item on Audit Committee, but I'd probably appreciate just a deeper dive in one of our meetings coming up around the register. The second thing was just an observation that I realise operationally there will be lots of risk assessments around COVID, etc. But it does just feel to me that there's a gap in our register that we just don't mention COVID at all, and it just I wouldn't want it to be swamped with COVID-related issues, but even a more generic issue about concerns on our performance in terms of lists with standing backup services over the next year, or something of that ilk feels like it's a bit of an omission at the moment to me.
Yeah, thank you very much. And in view of our earlier conversation of delaying the prioritisation of business cases and the planning, there is definitely something around that should be incorporated within that. Justina, you are on the call, I'm going to say, is that something that you can draft along with Andy and then take to committee?
Absolutely, yes, Chair, thank you. As you know, the Governing Board have the assurance framework, which are risks against our strategic objectives. And I think one of the strong positives throughout all of the pandemic is that actually our strategic objectives are standing fast. And so, in fact, some of the work and relationships that have developed and strengthened throughout this process have supported the scoring within the assurance framework. As you're aware, the corporate risk register is the bits that sit underneath that support that scoring. And I absolutely agree that we probably need to have a little bit more of a look around that. You will see that I've highlighted a few of those risks on that corporate risk register for review anyway. So some of them probably need to be considered for rewording or rethinking, EU exit being one of them. And some of them we may want to take off altogether. So it will be an action that I'll take, Chair, to make sure that we've got that updated. It will next be seen at the Audit Committee in March, and we, of course, will be bringing it back to the Governing Board as well.
Right, thank you very much. So, Margaret, you're on mute, Margaret.
Just wanted to mention that, just to agree with the idea of a deep dive into this, because some of the risks, don't get the wording that describes the risks, don't describe a risk so much as a kind of just a status position, yeah, a position that we're currently in rather than the risk itself. The other thing is the scoring. For example, with primary care, I'm not sure I'd score it as low as currently it is. So I think the pressures on primary care are such that they probably need to have a higher risk score than that. But that should be moving over time, and I'm happy to leave it to the Audit Committee to look at it.
Right. Other comments? Right. I do apologise about my irritating pinging going on. I don't know how to turn it off, so apologies for that. So, do people want to make any other comments about the risks highlighted for the QIP savings? We've discussed the EU exit, and there's the wheelchair service. Any other comments or questions? Or do we send this back to Audit Committee asking for a review and ask for people to consider the COVID pandemic impact? So we've got Alison and then Andy.
Hi, Elizabeth. Just to say, I'd support us having another look at the way in which risks are framed, because there's a number of risks where it's a bit generic, and I think something that is more about what situation might we genuinely be facing, and might genuinely be facing the residents, and how we're addressing them, rather than if we don't use our resources correctly, X, Y, or Z. I just think we need something which is a bit more punchy and a bit focused on residents' experience, which would perhaps support also covering the COVID crisis as part of that.
Thank you. Andy, you want to come in?
Yeah, thank you, Chair. Yes, with all of those points that are raised on the paper there, we're more than happy through the Audit Committee to dive a little deeper into them and just give a bit more scrutiny. As we are any other subjects that people identify with, feel the Audit Committee could have a little more of a delve into, we're always happy to receive recommendations from anybody on any of the work that the CCG does. So don't be shy to come forward with anything you think that we could dig into. Please do.
Right, thank you very much. So we will send this back to Audit Committee and ask for the reviews as requested. Thank you very much. And I have to apologise because I have also missed out other things off the agenda again. So quality and safeguarding report from Karen. We go back.
Thank you. Thanks, Elizabeth. My update's going to be very brief. You haven't got a report this month, and I think you might recall that back when we last had a governing board, I discussed the capacity of the quality and safeguarding team to be able to produce that report because they're because of staffing in one instance, but also because they were providing practical advice and support during this second wave of the pandemic. And also they're very conscious of the provider services, and they didn't want to be too intrusive into the services at the moment. Just a couple of things, I guess, for the governing board. PHU, as we probably already know, they're experiencing significant system pressures, and obviously waiting lists are unsurprisingly growing. And as Helen said, nearly 2/3 of our QA beds are taken up with COVID patients. So COVID is really having an impact at the moment on our PHU services. What they have done, though, that we haven't noted, is that the children's ED has moved from the ED department, from the emergency department, to the children's assessment unit, and this is to free capacity within the ED. So that's been a change that's probably worth noting. The Practice Plus group, which we're all getting used to saying is the Old Care UK, which runs out of St Mary's Hospital, they're now taking on all of the diagnostic work. And what we're hearing is that the minor injuries unit is now working to capacity and working quite effectively. I think previously we had concerns about them diverting COVID positive patients to QA, but now they've been supported and they're now taking patients that all have minor injuries and have are COVID positive. So that's a good piece of news. From the care homes perspective, obviously we know that the national vaccination programme has commenced into care homes, and the quality team are still providing, a year on, significant advice regarding infection prevention and control. So, finally, around safeguarding, another piece of positive news, we've had a safeguarding specialist nurse post vacant for nearly a year in the CCG, and we have just successfully recruited into that post, and we're hoping that they'll start in February. So that's a positive piece of news to end on. That's really all I've got to say, Elizabeth.
Thank you very much, Karen. Have people got any questions? Andy, your hand is up, but I think that's from last time. Anyone else with any questions for Karen? No, thank you very much. Thank you. So if I'm right on the agenda, I think the next thing should be the re-procurement of non-emergency patient transport service. Am I right this time?
Yes, you're correct, Elizabeth. Yes.
Right, thank you. Thank you, Ines. Over to you.
Hopefully this will be a brief, and I know Michelle is aware of some of the issues around this as well, and can come into the discussion. It's a request to approve the extension of an existing contract we have with the non-emergency patient transport service. Our CCG is one of a number of CCG commissioners who are party to this contract across the Hampshire and Isle of Wight area. Due to the COVID pandemic, this contract was extended in July earlier last year, and the paper sets out the procurement process and advice on that. Given that we are still in a similar situation, potentially more pressurised because of winter, etc., it would seem reasonable and practical to extend this contract again. The non-emergency patient transport service is a vital bit of making sure the health and care system runs. The current provider has demonstrated flexibility in responding to the changing context of COVID as well, and the various changing guidance that comes along with it as well. So I think it would be more of a risk to us to cease the contract than there is in extending the contract. The risks around the procurement process of extending the contract are explained in the paper, but our procurement people are saying that in the current climate they would judge that risk to be relatively small as well, and they've also set out the reasons for the extension. The issue that Michelle and I have already picked up, as you would have guessed, is that whilst we could make the assumption that the financial impact of this is no different because it's part of existing commitments, the sums given in the paper are for the totality of the contract, and I would guess and I would know that, excuse me, Michelle would want to just clarify that the Portsmouth contribution is as expected and as per our planning assumptions as well. I don't know, Michelle, if you want to add anything to that.
No, I think you did that much better than I could have done in this. Yeah, it is really a request to make sure that we're all comfortable with extending the contract, and I would agree with Ines that it's less of a risk to extend than it would be to start a procurement process just at this moment in time.
So, any questions or comments to Ines or Michelle about this? Graham.
Ines, I think I'm being particularly dense in this question, but I could, from the paper, be absolutely clear about when the current agreed extensions actually run out. So is it running out in March 22 at the moment, or is it running out in March 21 at the moment, I think is my question.
I think it's March 2022, Graham.
So the extent that you're requesting is from March 22 onwards. Right.
Absolutely, because we would have to start the procurement processes now in order to achieve a March 22 change. Does that make sense?
Yep.
Yeah.
Thank you.
Just a quick question. Do we have any issues over quality of this service? Anything being highlighted?
Nothing's been flagged up to me. We are aware that on the whole, it is a very good service, but we are obviously aware, as with a lot of services, that some residents will experience less quality than we would expect, but that's dealt with in the usual way at the moment. But we haven't seen any increase in those instances as a result of COVID. On the whole, this provider has been exceptionally flexible right the way through the pandemic.
Lovely, thank you. So, are we happy to agree to this extension?
Agreed.
Yeah, lovely. Thank you very much.
Elizabeth, you're on mute.
Apologies. Trying to stop my pinging going on. Right. Due to my erratic going through the agenda, we are now on item 10, minutes of other meetings. Have people, I'm not going to go through them individually, but are there any particular concerns or queries on these papers that have been presented? They're for noting. Right. I will take those as noted. I am then going to move on. We've got the date and time of the next governing board meeting, 17th of March at 2, which again will be a Teams meeting and streamed. And I would like to close the meeting today with a very big thank you to a lady who has not been on our board, but Tracy Sanders has been behind us and working so hard for us as an organisation for so long that I'm very sorry you can't be doing this with her here. But she left the organisation on Monday and in her inimitable style has done it very quietly and just gone. We've not even had the opportunity to thank her on a Teams or Zoom meeting. But I would like to extend our thanks as a board for her tireless work over so many years. I can't work out quite how long I've worked with Tracy, but it's most of my commissioning time. And that is a long period of time. She must have been incredibly young when she started, but she's been an amazing support to the organisation. She has got us through difficult times, and I personally will miss her, and I'm pretty sure that I am speaking for most of the board in that, and I would like us to extend our very grateful thanks for all the work she has done for us. Are people in agreement of that?
Absolutely.
Yeah.
Absolutely.
Absolutely.
Right. I will draft a proper letter and send that to her from us, and I'll do that tomorrow. So with that, I would like to close this meeting, and if we could end the recording, Peter, please. And Jane, you could end the recording as well.
That's done.
Thank you, Jane.